Hi, this is John Karwoski with JDJ Consulting. We provide consultant pharmacist services for surgery centers throughout the country. Today, I'd like to discuss malignant hyperthermia, its identification and treatment in our ambulatory centers. As we know, all licensed facilities throughout the country must have annual in-servicing and drills on response to malignant hyperthermia crisis. So today I'd like to just explain this topic and hopefully allow you to prepare yourself to participate in the treatment of malignant hyperthermia if it presents itself at your center. It was first discovered in the 60s. Although most of the reactions to malignant hyperthermia are from anesthesia agents, sometimes stress and trauma precipitate this event. We know that children under the age of 15 account for over half of the MH cases reported in this country, and males slightly higher than females. The rate of occurrence is estimated. It is actually unknown. We like to report all cases of MH in this country, but unfortunately, that does not happen. So we're going to try to have a range as frequent as 1 in 5,000 to as rare as 1 in 65,000 administrations of general anesthesia agents with triggering drugs. The incidence also depends on concentration of malignant hyperthermia families in a given geographical area. As we will learn, this is a genetic condition. Mortality can be as high as 70%, but with proper training and education and response times and drugs for reversal of this event, our mortality is less than 10%. Mortality usually results from acidosis, hyperkalemia, or organ failure. Pathophysiology involves the muscle cell, the skeletal muscle cell, calcium release from the skeletal muscle cell. This intracellular hypercalcemia leads to hypermetabolism. The hypermetabolism really is the problem that needs to be turned off, because as a result of this metabolism, many things occurring in the patient's body are affected. And we really need to have this identified and treated as quickly as possible. As I said, it's a genetic condition. It's a susceptibility pattern with an autosomal dominant inheritance trait. This means that children and siblings of patients with MH susceptibility usually have a 50% chance of inheriting the gene, and hence would also be an MH susceptible patient. They therefore may develop an MH reaction upon exposure to triggering agents. What are our triggering agents? Well, there is one paralyzing agent, succinylcholine, usually found on all anesthesia carts in operating rooms throughout the country. When we do general anesthesia, the halogenated volatile anesthetics are also triggering agents for malignant hyperthermia. Typically, we see isoflurane, desflurane, sevoflurane present in our surgery centers. There are many safe agents that anesthesia uses every day to perform sedation during surgery: local anesthetics, lidocaines, bupivacaines, narcotics such as fentanyl. Ketamine is a safe agent, barbiturates, nitrous oxide, propofol or diprovan, etomidate, and benzodiazepines like Versed are all safe agents and not a risk for precipitating malignant hyperthermia. There are also many muscle relaxants that are safe: pancuronium, vecuronium, and most common in surgery centers, rocuronium, all safe to provide paralyzing in and during surgery that do not result in a risk for malignant hyperthermia. So an important step during our intake of patients is asking an important question. Have you or your family ever had problems with anesthesia or surgery in the past? Both the nurse and the anesthesia provider get these questions answered. Very important to rule out a potential history of malignant hyperthermia in a patient, because that can result in the cancellation of a case or different processes in performing a surgical procedure in a surgery center. The pediatric assessment, as we know, has a higher risk when they present with muscular dystrophy conditions. Also diagnosing susceptibility, we can have a caffeine halothane test formed, but rarely, due to not many centers available in the US and a very expensive price. Most clinicians will inform families that have had an MH event to inform all family members when going in for a surgical procedure that there is a history of malignant hyperthermia within their family. That and that alone is enough for the anesthesia providers to possibly cancel a surgical procedure in a surgery center in the act of maybe performing this in the hospital. So again, we have our anesthesiologist making a decision. If the procedure is going to be occurring in the surgery center with a patient that might be at risk, we want to do some monitoring, we want to do some preparation, and we may prevent undue stress by pre-medicating this patient. Anesthesia will plan for regional anesthesia. As I said, many non-triggering agents are available to perform multiple surgeries. But if general anesthesia is necessary, that procedure probably will not be performed at the surgery center due to the risk of triggering agent exposure. So how do we diagnose this event? And again, early diagnosis and beginning of treatment is critical. We definitely see tachyarrhythmias, tachycardia, acidosis. An important indicator for the anesthesia provider is a sudden increase in the end tidal CO2. This can be rapid or slowly increasing, but never returning back to normal. Recently, we had a case in the Pennsylvania area where the CRNA began to see an increase in end tidal CO2 and called the anesthesiologist and nursing director in. They called the crisis and began treatment of malignant hyperthermia, which it was successfully completed on the patient, and 100% reversal occurred. Something to really pay attention to when we begin to see the earlier signs is muscle rigidity, also early in this reaction. Please remember that temperature increase, although very dangerous in a malignant hyperthermia event, is usually delayed and something we do not want to wait to identify before calling the crisis. When we respond to an MH crisis, we need to have an announcement made throughout the facility. I suggest an overhead announcement, MH to your location, repeated times 3. All clinical staff need to be able to respond. The surgeon is asked to stop the procedure as soon as possible. The anesthesia provider is now in charge of the care of the patient. They will discontinue any triggering agent, change the anesthesia machine and disconnect breathing circuits, flush the CO2 absorbent with 100% O2 and hyperventilate with 100% O2. They will now have the circulator page the anesthesia technician for the MH cart, call for additional nursing support, assist anesthesia with anesthesia machine, placing IV lines and possibly drawing blood as needed. And now our nursing staff will be immediately assigned to mixing the rescue drug, dantrolene sodium. Dantrolene sodium can be Dantrium, Ravanto,
or Ryonodex, depending on the manufacturer. This is critical in our ASCs to begin preparing, administering this rescue drug. All of our nurses need to be competent in preparing the rescue drug. We will also have staff assigned to cooling the patient as necessary. Ensuring the anesthesia technician has the MH cart present and cooled saline and ice and various forms of cooling available as needed when temperature begins to elevate. The code cart is also required to be at the scene, and medications such as bicarb, insulin drip, calcium chloride, mannitol, Lasix, antiarrhythmics are all readily available and at the fingertips of the medication nurse at the call of the anesthesiologist. The cooling nurse will perform and assemble an NG tube, Foley catheter, rectal tubes, all in anticipation for cooling. NG tubes, Foley catheters, possible lavages, all in anticipation of cooling. Each patient temperature fluctuations varies, so we are going to rely on proper monitoring and proper response to temperature fluctuations. The dantrolene nurses, hopefully 1, 2, 3, possibly 4, will immediately begin mixing the rescue drug. This requires each vial of 20 milligrams of drug to be mixed with 60 mLs of sterile water for injection. Please remember that this must be preservative-free sterile water. We're going to get our syringes, our vented spikes, and our vials of water and begin to prepare rescue drug. As many as possible, as quickly as possible. I also have a video on the proper mixing of dantrolene sodium if staff would like to view that. But again, this continues until we see a reversal. We start at a loading dose of 2.5 milligram per kilogram, which someone will be able to calculate with a dosing chart that is on your cart. This can continue to be repeated up to a 10 milligram per kilogram total dose. JDJ Consulting has videos on mixing if the staff would request this. Also, my recommendation is that all nursing staff or staff mixing dantrolene have practiced this preparation. It is a skeletal muscle relaxant. It inhibits the calcium release during skeletal muscle contraction. Very important to reverse this reaction and transfer this patient to the hospital where they'll be maintained and monitored in an ICU bed under the care of the anesthesiology department. And again, sterile water for injection is the only diluent that it can be prepared in. It is given as an IV push. It dissolves very quickly with the new formulation, but it's not stable for a long time. So we want to mix and administer as soon as prepared. There are various brand names, as I mentioned, Dantrolene, Ravanto, Redondex. These are the websites for the various products. Remember, Ryonodex is a different formulation, a more concentrated formulation of the initial two products. But again, anesthesia providers need to be involved with the selection of agent at your site. mHealth is the official organization for tracking and assisting in all rescues of malignant hyperthermia. They have a hotline available 24/7, staffed by an anesthesiologist. And that phone call should be available at all phones in the surgery center, and staff calling this number as requested by the anesthesia provider as soon as possible. Believe me that this is the most important thing when talking to centers that have had an MH crisis. The assistance of this specialist in guiding you and your staff and your anesthesiology department in treating MH is imperative. After our initial actions, cooling the patient stops when they reach 100 degrees Fahrenheit. We need to now prepare to transfer to a hospital where they'll be monitored for the next 24 hours because this event can reoccur and additional rescue drug may be administered by providers after they leave your facility. While most cases of MH occur during general anesthesia, the 1 hour period immediately following surgery is also critical. Our recovery room nurses need to be able to detect the event and assign the mixing of dantrolene and cooling if this were to occur in our recovery room. It is a true perioperative emergency that requires proper teamwork, preparation, and training. This all can prevent serious adverse consequences. Important for all of us to know and understand our roles during an MH crisis. Ask questions, be familiar with the cart and rescue drugs, and be well informed as part of the rescue team.